Hi, everybody. My name is Tina Aswani Omprakash. I'm a patient advocate for digestive diseases, specifically Crohn's disease and gastroparesis. What that means is that I talk to a lot of patients, I talk to a lot of gastroenterologists about what's going on, what the latest is in these fields. And I'm also studying for my public health degree, a master's degree, to really sort of understand how this sort of folds into the public health space. And I live in New York City. And thank you so much, Dr. Higgins, for having me here today.
Yeah. So we're continuing, and this talk sort of wraps up our stressors in IBD theme. But for everyone, COVID-19 has been a stressor, but particularly for folks in New York, especially early on in Michigan and especially Detroit. This hit everyone really quickly and really hard. And we just got swamped with questions about COVID-19 and IBD. So I want to try to address these with Tina and myself, talking about patient experience, physician experience of COVID-19 and IBD. So I am going to try to expand this so you can see more of it. And we'll get started. So in March in Michigan, both New York and Detroit were hit very hard. There are a lot of historical ties and a lot of flights between New York and Detroit, and we were recently connected by a measles outbreak last year, which probably no one remembers, but there were a lot of folks flying back and forth, and a measles outbreak occurred almost simultaneously in New York and Detroit. Unfortunately, that sort of foreshadowed what would happen with COVID. And probably the lowest point in the Detroit area was at the Sinai Grace Hospital. On April 6th, they had 95 COVID patients in their ER, and their capacity is more like 70 people normally. Half of those patients were on ventilators. There were only 7 nurses and 1 trainee nurse assigned for a night shift to take care of those 95 people. Of about 48 were on ventilators. As you can see from this screen capture from the news that night, the nurses walked out. They demanded more help and walked out from the hospital. Knowing a lot of nurses, they had to be desperate to be at that point. And apparently, and this is by word of mouth, a lot of the folks early on who died were folks who were insufficiently attended, who actually pulled out their ventilator tubes because no one was able to keep track of them. There were just too many people on ventilators at once. Typically, you have 1 nurse for every 2 patients on a ventilator. The University of Michigan set up 2 field hospitals with a capacity of 1,200 plus beds, but in the net, less than 30 patients were transferred, which says a lot about our US hospital system, our medical care system, but was very disappointing. And I think there were opportunities to coordinate better, but it didn't happen, unfortunately. COVID-19 overall in Michigan, new cases peaked at about 2,000 per day on April 3rd, now around 900 per day. Deaths peaked at 230 per day on April 21, now quite a bit better, partly because we're a lot better at treating COVID. We've learned a lot along the way. But we got a ton of questions. We didn't know a lot and we were scrambling, but we were getting questions like, does my IBD therapy increase my COVID risk of getting infected? Should I stop my IBD therapy? Is it safe to come to the hospital for infusions? On the other hand, are home infusion safe? Having a nurse who's seen 6 other patients come into my house, is that a good idea? And should I stop an effective IV therapy and switch to a self-injectable just because of COVID-19, even though my therapy works? And at that time, we really had no good answers. And that's sort of our experience starting out from the Michigan perspective, but I'll turn to Tina now for the New York perspective.
Absolutely. Thank you so much, Dr. Higgins. So a little bit more about me and my patient experience. And one of the things I wanted to highlight is actually my patient experience because I think this shows on a more detailed level what patients are going through during the COVID era. So just a little background on my Crohn's history. I've had Crohn's for nearly 15 years now and a permanent ileostomy for nearly 9. Happy Ostomy Awareness Day to those of you who might be celebrating today. I've had over 20 surgeries. I was initially diagnosed with ulcerative colitis and given a J pouch after a couple years of severe disease, and went through multiple fistulas and abscesses and eventually a J pouch excision. I've dealt with multiple extraintestinal manifestations, joint, skin, eyes, basically all over my body as a result of inflammatory bowel disease. And as you all know, I live in New York City, which was initially the epicenter of the US COVID epidemic. I am in the heart of Manhattan, and I am on a biologic and an immunosuppressant. And there was, like Dr. Higgins said, not much known about what that meant about our risks as IBD patients early on. I'm also asthmatic. I have trouble breathing, and in the spring it was really hard because I get springtime allergies, and I had traveled a lot in the couple of months prior, so I was really afraid that I might have contracted this, and that sort of goes along with some of this anxiety that we've been talking about the last few presentations, is sort of building up as a result of this new epidemic that we're now facing. A lot of what I do and a lot of what I've been doing over the last 7 months is creating content around COVID and IBD. So really helping to bridge the gap between patients, caregivers, and GI doctors to really understand and bring the latest information that doctors might have over to this patient community to allay some of that anxiety. Now, one of the things that I dealt with that I have to highlight really built up my anxiety towards COVID was a near-death experience in 2016 with influenza A. What had happened to me, just briefly, was in December 2016, I had not been inoculated against the flu, which was a big mistake, and I had traveled to San Diego. On my way back, and this is a long flight for me, it's about 6.5 hours, I must have picked up the flu because within 5 days, I developed prodromal symptoms of sort of labyrinthitis in my brain, which is like a form of vertigo. And I was walking the streets like falling, and like I had no idea what was going on with me. I was put in observation in the hospital. They watched me for a couple days until I coded. And when I coded, that's when they swabbed me and found out that I had influenza A, and they said this could have killed me. And I had viral gastroenteritis. I had the infection, the viral infection in my brain. It took me 4 months to recover from that labyrinthitis. I was walking around New York City with a cane and with very little balance, dealing with vestibular migraines. So understand that sort of experience with the flu was really compounding my anxiety towards COVID-19. Next slide, please. So this is all going into the pandemic. I had this really severe PTSD from my flu experience. I also had ruptured my ankle just a few months prior, right before Thanksgiving, and was going to physical therapy for this and traveling to conferences with the boot on. And I had multiple ER visits because now I had a herniated disc in my neck. So something that happens to a lot of us IBD patients is we have a lot of comorbidities, whether or not they're related to IBD. It's something that I always say, that we accumulate some of these diagnoses. So I was dealing with a lot of things at once and having to sort of manage my health alongside school, alongside, my advocacy work, and then facing a pandemic. I think this is something that a lot of us with IBD were facing, and it was causing a tremendous amount of anxiety. Next slide, please. And I think really the shock of the pandemic hit me maybe 10 days or 2 weeks into, things going really south in Manhattan. You'll see a picture here on the left of, a prominent avenue in Manhattan. This is about 7 p.m. in mid-March. The street is completely empty. Mind you, this is still considered rush hour in Manhattan. The streets are packed. It was eerie. I also was really afraid for my life hearing the news coming out of countries like Iran, Spain, Italy, that, patients with pre-existing conditions might be considered dispensable or expendable. And I was really afraid that, look, if I picked up anything, on New York City subways or in my travels, what would happen? Or if my husband picked up something at work, what would sort of happen? And there was a lot of fear, a lot of anxiety around his job, which I know a lot of patients are also facing along with their caregivers. Another thing that, was causing a lot of stress during this time was the rapidly changing information. Do we wear a mask? Do we not wear a mask? That, of course, applies to the general population, but then do we stay on our biologics or not? Like Dr. Higgins was mentioning, do we switch to an injection versus an infusion? There were so many questions coming at doctors and coming at patient advocates like myself, and just so much in general stress around what do we do as patients? Are we more at risk because of this? Which we now know a lot more about, and I think Dr. Higgins will go into that. But another thing I really wanted to highlight is how difficult it was to receive ongoing care during this time for chronic illnesses. As I mentioned to you, I have multiple comorbidities. Not being able to receive proper treatment for, the herniated disc in my neck, for instance, going to pain management, or going to physical therapy, or receiving proper treatment for gastroparesis during this time was very, very hard on me. And I did notice that many of my symptoms got worse. And you will see to the right, I'm at the New York Eye and Ear Infirmary. I took an Uber there, because I did not want to expose myself to the subway. And I was terrified getting into the Uber. And that's been the case throughout the pandemic. But you'll see I have active episcleritis, which is an extraintestinal manifestation, from what I understand, of IBD. My eyes are red. I dealt with this all of the spring, could not get proper care. My doctor could see it virtually, but it was very hard to treat because she needed to do more intense examinations on my eyes. So these were all really tricky things that a lot of us patients were dealing with. And come June, and you'll see this in the photo in the bottom right, with some of the riots and protests going on around the Black Lives Matter movement, New York City really changed drastically. You'll see here, this is Greenwich Village. This is after an appointment of mine, where you'll see a CVS pharmacy is boarded up. So a lot of us were afraid we wouldn't be able to access our medications. It was a really, really tough time for us emotionally and physically, knowing that we might not have the access to care that we might need. Next slide, please. During this time, I think a lot of us started to adjust to a new normal. As a patient and advocate, obviously I was staying on my meds. You'll see me here taking my medication, and this is something I was showcasing to the patient community to make sure they stay on their meds, make sure they speak to their doctors about, having a game plan regarding their medication and compliance with their medications. On top of that, I was staying abreast of rapidly changing information to help allay some of the anxiety for myself and for other patients. And of course, informing the patient community, who was very obviously terrified, as is expected and completely normal. In everyday life, and I think this is something that I've been hearing from other patients as well, we started spreading our focus to other things so that COVID would not sort of take over emotionally and mentally. I know I spread my focus to really grad school virtually, as well as my advocacy work. I started developing new hobbies. I learned I could cook all of a sudden. And I started going for walks. That was sort of my only outing during the day. And it was one of those things that I knew could help my health, especially my motility. Next slide, please. Now, stepping into summer and fall, I think New York City really experienced a lull during the summer, which was, tremendous. It was a tremendous accomplishment in the sense that we had some of the highest numbers going into the pandemic. And then, some days over the summer, 0 deaths, or 1, 2, or 3 deaths, which I thought, just speaks to the volume of how much we socially distance and how many people were wearing masks here. So during this time, I noticed myself and speaking to other patients, a lot of us were focusing on improving our mental and physical health during this time. What did that mean? So I went for a lot of my in-person maintenance, doctor's visits and procedures. You'll see in the bottom left, I'm here for an abdominal and pelvic MRE, which I had delayed by 2 months because my doctor had asked me to push this off until July when things were a little bit calmer. And then a lot of the other things that I went for were OBGYN sort of yearly visits, pap smears, also going to see my primary care for a physical, also going to see my dermatologist because annually we should be checked out, especially if we're on immunosuppressants and the combination of biologics, to make sure that there aren't new skin spots developing. So these kinds of things that I knew I had to do in person, I sort of scheduled for the summer to make sure that my exposure to the virus would be less. And I would put this out to the patient community so that they would know that this might be, depending on how things are going, talk to your doctors about whether you should be completing some of these maintenance appointments at this time. I also, like I said, was really focusing on mental health. So I was trying to find ways to, before the winter, before, this possible second wave that everybody was talking about, to staycation, to go to the beach, to visit family, and I would get tested beforehand and sort of visit them in a playground, on a beach, or in the park to sort of get that exposure to seeing some of my friends and family and making sure that, I'm really taking care of myself and my family emotionally. Now, going into the fall, which is where we are now, we're starting to see numbers rise here in New York again, and it is a bit scary. We don't know what this means and how far this will be extended, meaning how far this will grow. I think for me personally, I'm gearing up for what might be a second wave. It's one of the things that I focused on heavily in my public health program last semester, is coming up with policies around how to manage a second wave in New York City. So this is something that's been on my mind, something that I'm working towards, and really pulling back a lot from some of these social visits and making sure that I'm taking care of myself and my body at this time. Another thing that I've done that I know a lot of patients have questions about right now is, how do we protect ourselves from vaccine preventable illnesses? So I myself got the flu shot last weekend, and I understand it takes a couple of weeks to start working. And I got the pneumonia vaccine last year. I get that every 5 years, just to sort of ensure that whatever I can prevent, I will prevent, because we don't have a COVID vaccine right now. I think there's a lot of buzz in our community about, and I've been getting this question a lot, and I'd love if Dr. Higgins could maybe go into this a little bit, should we get the vaccine, the COVID vaccine right away? And I don't think there's necessarily an answer for that. I think what I've been telling the patient community is really wait for your doctors to give you the green light, wait for your GI to tell you. And I think some of the tips and tricks that I would suggest during this time is really focus on your mental health. This is just, COVID-19 is just as much a mental health sort of stressor as it is a physical health problem. And the mental health aspects are really affecting everybody around the world, especially those of us with pre-existing conditions who have a lot of worries. So focus on mental health, focus on things that make you happy right now. One of the things that I learned from this pandemic is, don't overwork yourself, because I felt like I did in order to distract myself from this virus. So I have pulled back. I'm trying to focus on making sure that I do the things that I love, as well as doing the work that I love. So I think these are some of the things that are important to me and some of the things that I've seen in the community. Thank you. And I just wanted to pass this off to Dr. Higgins now, who will go into this some more.
Great. And in this transition, I'm actually going to take a moment to launch a quick poll. So you should see this on the screen momentarily. What have you worried about during the COVID-19 pandemic? And select one or more, and you can select several. Does IBD make me more likely to get infected with the virus SARS-CoV-2? If I get infected, am I more likely to have severe COVID-19? Should I stop my maintenance IBD medications? Should I avoid endoscopy at this point? And should I avoid in-person clinic visits at this point? So go ahead and put in your answers. I'll give you another, say, 12 seconds or so, and select as many as are appropriate for you, that are questions for you. And I will keep the poll open for a few more seconds. It looks like at the moment, the question about severe COVID-19 may be the leader, although there are a lot of positives there. So I'm going to go ahead, close the poll and share the results. So the number one was, if I get infected, am I more likely to have severe COVID-19, which I'll go through. Does IBD make me more likely to get infected? Should I, followed by, should I avoid in-person clinic visits, endoscopy, or stopping maintenance IBD medications? So that's a great response, and those are all important questions we got a lot of during the early days of the pandemic. So the big question is, how do we get answers? And this is what we were facing in April. You can't do a randomized control trial. It would be wildly unethical to randomize IBD patients to give half of them an infection and half not. So the IBD community worked together to start a registry of reported cases, and this was led by Mike Kappelman and Erica Brenner at UNC, helped by Ryan Ungaro at Mount Sinai in New York, called Secure IBD. And you can actually go and see the data. They actually put it on a public website. So if you go to this link, you can see their current data. They collected data on risk factors, IBD meds, and how people did, whether they needed to be hospitalized or put on a ventilator, or whether they died. And these are largely reported by doctors through a secure system that allows them to keep everything anonymized. In general, and I'm summarizing here, it's mostly reassuring data. IBD patients don't do a lot worse with COVID-19 compared to non-IBD patients. The rates of hospitalization, ventilators, ICU care, and death are about the same. But the big question they had was, does the medication you are on, especially if it's immunosuppressive, matter if you get COVID-19? And this is where it got a little bit interesting. Now, there are limitations to the data. There could be biases in reporting. We might report more of the people who did terribly and fewer of the people who did well, more reporting in some countries versus others. And the numbers aren't huge. It's over 2,400 cases, but it's the best data we have. And it's not big enough to get all the effects. You could miss small effects, but big effects you should see with 2,400 cases. And what we now know is that IBD patients on average don't do worse with COVID-19, but similar risk factors matter. Older age makes you have worse outcomes. Obesity makes you have worse outcomes. Comorbidities like diabetes and hypertension lead to worse outcomes. A lot of the damage from COVID is from severe inflammation, which could possibly do better with IBD meds. And some of those IBD meds, like Xeljanz or other JAK inhibitors, are actually being tested as therapies during COVID infections. They did see a lot of blood clots, and more of these happen with more severe inflammation, and especially in the early phases, more with steroids. When we looked specifically at IBD patients in the Secure IBD database, steroids are associated with worse COVID-19 outcomes, about 7 times more hospitalizations, death, ICU stays, and ventilators. And to our surprise, 5-ASA medications were also associated with worse outcomes. Not quite as bad, about 3.1-fold more of those bad outcomes. In general, most IBD therapies appear to be neutral in terms of producing bad outcomes, and some, and there are just 2 examples, anti-TNF therapy alone, not in combination with anything else, and ustekinumab or Stelara were associated with not quite significant, given the numbers we have, but slightly better COVID-19 outcomes. The numbers are small, so it's hard to make a definitive statement there, but actually it seemed like lowering the inflammation may actually be helpful in avoiding the really bad outcomes. And not needing to go on steroids for a flare seems to be really important. So what we know now, in general, public health measures work when they're used. Masks, distancing, being in well-ventilated or outdoor spaces really do seem to help in terms of reducing transmission. Our hospital treatments have improved, anti-clotting therapy, remdesivir, and there are a lot of trials going on, particularly with monoclonal antibodies and anti-inflammatory therapies now. Unfortunately, the virus itself is not going away. We really have to do better things and probably have an effective vaccine. Other lung infections likely increase your risk, and that's the worry with flu season. I got my flu shot 2 weeks ago, and I think it's important to protect yourself against the flu because A, it can be confusing whether it's flu or COVID, but B, the damage that flu can do to your lungs can make you more susceptible to other infections, and that's really important. There are several vaccine candidates that look promising in early studies, but it may take, even after they get approved, another 12 to 24 months to produce enough vaccine, distribute it, and give it to sufficient doses to people worldwide to really stop this pandemic. I want to point out there are ongoing COVID-19 vaccine clinical trials. This is the link for folks who are interested. And I have volunteered. I'm hopefully going to be on day one of the local clinical trial. We're doing one that is a killed vaccine. Most of these are killed vaccines, which are very helpful for folks who are immunosuppressed. Generally, most of these trials are going to exclude people who are on steroids. They generally don't exclude people on other immunosuppression, but I think you should talk to the study teams and your doctor before you jump in. I think this is the case where maybe family members, your people who live in your household can participate because it's not a live vaccine and may be able to help protect you. This particular one, 2/3 of the folks get the active vaccine and 1/3 get sham. They need 30,000 people to enroll to complete the trial. So this is something your friends and family can do to help you and help everyone, really. And that's why I'm going to enroll. So take-home messages during COVID-19, use the public health measures to reduce your risk. Avoid unnecessary steroids. That's probably the biggest take-home. Stay on and use effective maintenance therapy for IBD. Monitor your inflammation regularly with your doctor, whether that's through CRP or calprotectin or a scope or a scan, whatever you can do to make sure your inflammation is controlled. Adjust your therapy as needed to avoid flares. Use whatever form of infusion appears to be most safe. If you're going to an infusion center and they're really taking care to make sure it's ventilated, it's not crowded, you have appropriate social distancing, and everyone's wearing masks, that's probably pretty safe. If your home infusion is also very careful, that's also possibly safe. It's really, are they taking the right public health measures? In general, don't change medications unless your current med is failing you. And if you're choosing a new IBD medication, right now during the pandemic, a self-injectable or oral medications are pretty appealing right now. So if you have good choices that are oral or subcutaneous, those are good choices right now. And now we're going to open up for questions. It looks like we already have some coming in. One is the pneumonia vaccine. In general, getting the pneumonia vaccine is a good idea for IBD patients. IBD patients have a higher risk of pneumonia, and immunosuppressed patients an even higher risk. Having pneumonia can temporarily damage your lung tissues and put you at risk of other infections. So it's a great idea if you can get the pneumonia vaccine. Another one, if you have IBD and are COVID-19 positive, and your symptoms are primarily diarrhea, nausea, and vomiting, which do occur with COVID in about half of patients. How do we determine when COVID-19 is no longer a major concern? It's a great question that comes from David Zimmer. That's a tough one. At the moment, we can test fluids, including diarrheal stool, for COVID-19. In Hong Kong, especially early on, they were testing people to make sure they had cleared the virus before they discharged them from the hospital. So I think it's reasonable if you are having diarrhea and COVID-19 to test that watery diarrhea to see if there's still active COVID-19 in that fluid to know when you're no longer infectious. We know that patients, from a few examples, who are immunosuppressed may have a longer infectious period, may have a harder time clearing the virus. We had a case of a patient in the hospital on an immunosuppressive med who took up to 8 weeks to really get rid of the virus. that can be more of a problem with immunosuppressed folks. Another one asking about the shingles vaccine. This is, depending on which vaccine you got, it might have been a live vaccine. Zostavax, the older one, is a live vaccine. We recommend the recombinant vaccine or Shingrix for IBD patients, especially those who are immunosuppressed. In general, the Shingrix is a very effective vaccine. It will make your shoulder really sore and may make you feel crummy for a couple of days, but generally people do very well with it and get strong immune protection. Any other questions, feel free to put those in. Tina, any perspectives on vaccinations at this point? Have you ever had the pneumonia vaccine?
Yeah, so I actually got 2 vaccines back in 2014 for pneumonia to initiate sort of that vaccine process. And then last year I had it renewed after 5 years. And my doctor, my GI doctors advised to get it again after another 5 years. So I feel pretty safe between having the flu shot and the pneumonia vaccine. I know there's been concern actually, and I wanted to ask you this, is patients have been asking, can you get COVID and the flu together, and what does that mean?
Right. I think you probably can. I don't have a lot of data yet, and we'll probably learn a lot more about this in the coming months. We know that, for example, flu can damage the lungs so that other infections are much more likely, and the most common one is H influenza B, which there's actually a vaccine for in kids called HIB for H influenza B, because, and it's named influenza because it so commonly infects people who've recently had the flu. So I think trying to protect your lungs right now is a really good thing, and preventing pneumonia, preventing the flu are really good things. In terms of pneumonia, we generally recommend the Prevnar vaccine first, followed by the Pneumovax vaccine. And then there's not clear data on how to do it, but we generally alternate boosting those about every 5 years. So a lot of times I'll give Prevnar at 5 years and Pneumovax at 10 years. We don't have a lot of data that the order matters that much, but just that we are doing boosters. In general, I might do that earlier if somebody's on steroids when they get the first injection, because that reduces your response to the vaccine by about 50% roughly. So that's an important thing. You may need an earlier booster if you got vaccinated while you're on steroids.
Absolutely. Now, one other thing, to allay some of the anxiety in the community, because I still see these questions pretty often about biologics and immunosuppressants. From what I understand, some of these biologics, like adalimumab, might be in clinical trials right now, as you mentioned. Is there sort of data yet on these being somewhat, quote unquote, protective against COVID-19, or making some of the cytokine storm symptoms a little bit less? What have you seen in your experience, Dr. Higgins?
So most of this is from retrospective data. It's not prospective randomized clinical trials. But if we had to look at that secure IBD data, it looks like JAK inhibitors may reduce the cytokine storm. Anti-TNFs alone, not in combination with Imuran or 6-MP, seem to reduce the cytokine storm, and possibly Stelara, although the numbers are still small. So overall, there's a movement, again, not completely based on clinical trials, of taking people from combo therapy to monotherapy if they're an anti-TNF. And if you have to make a change, thinking about using anti-TNF or Stelara or a JAK inhibitor at this time, given that those might help make COVID milder if you do happen to get infected. Overall, the number of infections in IBD patients as reported in Secure ID is quite a bit lower than you would have expected, quite a bit lower than non-IBD patients. And it's hard to know why that is. One real possibility is that IBD patients are just a heck of a lot more careful. And I think that's a pretty reasonable hypothesis, that when you say protect yourself against infection, wear a mask, do social distancing, as a general rule, IBD patients get it. They know the consequences and are smart about it. And so that may be part of why we're seeing fewer cases. But part of it may be that the anti-inflammatory meds given to IBD patients may actually make their cases milder. So they're either asymptomatic or they just aren't sick enough to get tested and get reported.
Absolutely. Just, to briefly, from a patient perspective, hearing from other patients, some of the things that I've heard, I've had friends who have been on biologics, maybe lost sense of taste and smell, but that was basically some of their major symptoms for 2 to 3 weeks. Other ones have had breathing issues, but haven't needed to be hospitalized. But I have seen from the older population that has IBD, they might have had more severe issues, but some of them have not been hospitalized. They were able to recover from home. And then I did see even from the younger population who might have had breast cancer, cervical cancer, some other cancers, these comorbidities to the IBD, they've taken several weeks to sort of recover. Just in speaking to different patients, these are some of the things that I've heard from the community. And I think a lot of what patients are wondering about now is, as we're heading into the fall, is it okay to sort of, this is going to be around for a heck of a lot longer. We don't know how long. Are small gatherings okay? Is it okay to go to the grocery store? Like, what sort of is a good practice for IBD patients? Because I know for me, I'm still avoiding the grocery store and I'm still avoiding gatherings of as much as I can, especially as I see numbers rising. And is this more of an individual thing based on preference, or is this more of a geographic thing based on where you are? I was kind of curious about your
Yeah,
thoughts.
I mean, it is the safest and smartest things to avoid gatherings, to avoid crowded places like grocery stores. Um, on the other hand, something that's open to the air and well ventilated, like a farmer's market, might actually be pretty reasonable. I think gatherings right now, if you can do it, would be best done outside. I think there's going to be a big market for ways to heat patios and porches so that people can have some gatherings through the winter. And the cafe technology of the space heaters is going to be really important, because as it gets colder, it'll be more and more tempting to be inside and at risk. So if you can figure out a way to go to places where there's good airflow, being outside, it really does make a difference. Where you're stuck inside in a heated space and there are a lot of people close together, the risk definitely goes up, for sure.
Thank you so much, Dr. Higgins. I appreciate your insights on this.